welcome to the Deep Dive. Today, we're plunging into one of the most compelling and frankly disturbing paradoxes of modern healthcare. Over the last 50 years, we have achieved absolute miracles, haven't we? We have technologies that can keep premature babies alive, we can replace major organs, and we have surgical skills that, well, they almost defy imagination. Yet, when we look at the systemic level, things like patient safety and satisfaction are still, sometimes frequently, compromised. So today, we are going to dive deep into the science of safety, specifically within these incredibly complex surgical environments.
It really is the ultimate cognitive dissonance in medicine, isn't it? We have the knowledge, the skill, the intent. I mean, the core philosophy is primum non nocere, first, do no harm. But the systems and structures we actually operate within, they're often decades behind the technical capability of the individual clinician. Our sources today, particularly focusing on the key chapter covering human factors and quality improvement, they give us a pretty comprehensive analysis. They draw heavily from surgical practice, yes, but they offer essentially a blueprint for creating genuinely safer healthcare systems.
Right, focusing on those human factors and the quality improvement side of things. That's our mission today, really. We want to give you that shortcut to being truly well-informed on this whole area. We are unpacking the core concepts that define this big shift in thinking, moving away from just blaming individual error towards embracing systemic analysis. This deep dive is all about understanding the foundational systems science that underpins, ultimately, surgical excellence.
And we absolutely have to acknowledge the immediate reality that's driving this transformation, the challenge facing healthcare. It's intensifying and rapidly. We're seeing a massive increase in demand. Patient populations are aging, they're often sicker, presenting with multiple comorbidities.
Yeah, needing much more complex care.
Exactly. They need increasingly intensive multidisciplinary care that spans multiple departments, multiple specialists.
And as if that patient complexity wasn't enough of a challenge, the treatments themselves are getting exponentially more intricate and costly. You've got advanced pharmaceuticals, robotic surgery, incredibly complex critical care pathways.
Right.
If the organizational structure doesn't keep pace with that complexity, the whole care pathway doesn't just get expensive, it actually actively increases the risk of error and failure.
Precisely. You've hit the nail on the head. If we don't structurally redesign these systems, the increasing complexity will just eventually overwhelm the capacity of even the most skilled clinician. It's almost inevitable.
Okay, let's unpack this then. Starting with that big picture idea of value and maybe how complexity first forced this critical reckoning in medicine.
Yeah, to really get the modern imperative for safety, we have to understand where we started. For decades, I think the assumption was, well, just throw more resources at it, more highly trained doctors, more technology. That would inevitably lead to better care.
Kind of intuitive, right? More stuff equals better outcomes.
You'd think so. But in the 1990s, maybe early 2000s, it became painfully clear that this just wasn't true. The relationship wasn't linear.
And that brings us to that really influential Institute of Medicine report, Crossing the Quality Chasm. It wasn't just a critique, was it? It felt more like a revelation that patients, despite all these advances, often did not receive the most suitable care at the best time or even in the best place. Why did they call it a chasm? That's a strong word.
It is strong, and it was called a chasm because the gap between the care that should have been delivered, based on current scientific knowledge and the care that was actually being delivered was, well, enormous, and it was growing. The report fundamentally argued that the traditional, fragmented, sort of specialty-centric healthcare model was just incapable of safely managing the complex needs of 21st century patients.
Wow.
It demanded that we stop trying to just patch up the old model and instead redesign the entire process of care delivery from the ground up.
So the realization wasn't that we didn't have brilliant doctors. That wasn't the problem. The system they were being brilliant within was fundamentally flawed. Is that fair?
That's a very fair summary. And this paradigm shift led directly to this critical concept of value. For decades, healthcare success was measured by volume, right? How many procedures did you do? How many beds were filled?
The throughput model.
Exactly. Professor Michael Porter, his work is foundational here. He argued we have to stop defining success by input or volume. In the value-based model, value is defined solely by the patient outcomes achieved, relative to the total cost of delivering those outcomes, and crucially, over the entire care cycle.
Okay, so the focus shifts from just doing stuff, the fee-for-service, to measuring whether the intervention actually made the patient healthier, more functional, and did it efficiently.
Precisely. Did we achieve the goal? And what did it take to get there?
It sounds, at first blush, maybe like a financial mechanism. Rewarding efficiency. But it's really about aligning the clinical goals with how we use resources, isn't it? If you get great outcomes achieved cheaply, that's high value. If you have mediocre outcomes achieved expensively, well, that's low value. Simple as that.
Exactly. It forces that connection. And Porter proposed 6 interconnected principles that institutions really must adopt to achieve this necessary alignment. These aren't just, nice suggestions. They form the operational framework for transformation.
Okay, let's run through these 6. Maybe analyze the intent behind each one, starting with how care needs to be organized. What's the first principle?
First, care needs to be organized around medical conditions, not around traditional departmental specialties. Think about a complex cancer case. Historically, the patient kind of bounces between the oncologist, the radiologist, the surgeon, the palliative care team, often operating in silos.
Yeah, you hear about that fragmentation all the time.
Porter proposes that the system must center on the patient's condition, let's say metastatic colon cancer, and integrate all the necessary specialists into a cohesive care unit dedicated to that specific condition, driven by community needs, not just the hospital's internal structure.
That sounds like a massive bureaucratic overhaul, because hospital structures, they're historically designed to protect those professional silos, aren't they?
Oh, absolutely. It's a huge challenge, but necessary. What's the second principle? This seems to be the engine of defining value.
Okay, second principle.
Second, we must measure outcomes and costs for every single patient. This is like non-negotiable in the model. You simply can't claim success or identify waste if you don't have robust data on both sides of that value equation. This involves measuring clinical metrics, things like survival rates, complication rates, but also critically patient-reported outcomes.
PROMs.
PROMs, so like functional recovery. Quality of life from the patient's perspective. Exactly, things that matter to the patient. And then linking that precisely to the financial expenditure, including all the costs incurred across the entire cycle of care, not just the surgery itself.
I can already see the institutional resistance kicking in there. Measuring cost across different specialties and departments, that's notoriously difficult in big siloed systems.
It is. But without it, the third principle, the financial driver, it just can't work.
Okay, so what's number 3?
The third principle is to align reimbursement with value. We have to move away from that traditional fee-for-service model where providers get paid simply for performing a service. That rewards volume and potentially waste.
Right, more procedures equals more money regardless of outcome.
Instead, reimbursement models, things like bundled payments for an entire episode of care, they must support better outcomes and efficient pathways. If a provider can deliver the same or even better outcome more efficiently and safely, the system should reward that.
Okay, so that tackles the financial fragmentation. What about the physical fragmentation of care, where people get bounced around?
That leads directly to the fourth principle, systems integration. The entire care process needs to be organized to match the patient with the appropriate treatment and, critically, the correct location. If a patient needs complex, highly specialized surgery, they should be funneled towards a specialized center, not just treated in a general hospital because it happens to be closer to their home. Integration prevents that fragmented care pathway, which, as we know, is just a breeding ground for communication errors and inefficiency.
And this ties directly into the 5th principle, doesn't it? The geography of care. This is about creating genuine centers of excellence.
Yes, exactly. For high-risk, low-volume procedures, think specialized aortic surgery or something similar outcomes are invariably better when they are concentrated in centers that perform them frequently. Volume matters for complex tasks. This principle dictates that complex care should be delivered in designated centers of excellence where expertise, specialized equipment, and resources can all be maximized to ensure the best possible patient outcomes. It really challenges that instinct to offer every single service at every single hospital.
Right, a jack of all trades, master of none kind of issue at a system level.
Precisely.
And finally, the essential infrastructure underpinning all of this transformation, something that's been a monumental struggle for healthcare systems globally, information technology integration.
Absolutely critical. The 6th principle is information technology IT integration. Value-based care simply cannot function without seamless, standardized IT infrastructure, period. This means integrated electronic health records that follow the patient across all care settings, enabling real-time data collection on both outcomes and costs. You look at the UK's NHS, for example, they really emphasize adopting a universal healthcare number and integrated platforms specifically to reduce fragmentation and eliminate those catastrophic errors that happen when information gets lost or delayed between different systems.
So, okay, the structural challenge of complexity forces us towards this value-based mindset.
Right.
But even within the most perfectly organized, integrated system, the human factor remains the ultimate variable, doesn't it?
That's the absolute hinge point of the entire discussion today. Once you address the structure, you must deal with human performance within that structure, especially in the high-stakes environment of surgery. So when we transition from that macro system view, the value-based care structure, down to the microenvironment of the operating room, we have to talk about human factors. HF. The surgical theater, you see, it's not a factory floor. It's an inherently complex, highly interactive social, cultural, and technological environment. Surgeons are required to integrate really high-level technical skill with knowledge and mastery of advanced equipment, all while simultaneously functioning within a highly dynamic, multidisciplinary team, often under immense time pressure.
Okay, so let's define this clearly for everyone listening. When we talk about human factors, or HF, we're looking beyond just the individual person, right? We're focusing on the relationship between them, the tools they use, and the environment they work in. It's that complex web of interrelationships involving teamwork, tasks, equipment, culture, organizational structure, all of it.
It's precisely that interdisciplinary study. HF seeks to understand how human capabilities and, importantly, human limitations interact with the system design. The goal ultimately is to design processes, interfaces, and environments that minimize the chance of error and maximize human performance. Fit the system to the human, not the other way around.
And I think it's really crucial here to draw a sharp line for the listener. HF training is not about teaching you how to suture better or how to correctly identify a piece of anatomy during dissection.
Correct. That's the key distinction, and it often gets confused. HF training focuses less on specific technical knowledge, like performing a perfect anastomosis or excising a tumor margin, and almost entirely on the non-technical skills. These are generally categorized into two buckets: cognitive skills and interpersonal skills. Both are necessary for effectively managing team-based high-risk activities.
Okay, cognitive and interpersonal. How do you separate those two buckets of non-technical skills? What falls into each?
Well, cognitive skills involve the mental processes. The most critical one is probably gaining and maintaining situational awareness. That means knowing exactly what is happening around you, understanding what's likely to happen next, and grasping the significance of the information you're receiving.
Like keeping track of everything simultaneously.
Yes, and processing it. It also includes things like problem solving and making rapid decisions when the original plan goes wrong, which happens often in surgery, like during an unexpected surgical hemorrhage, for instance.
Okay, so that's the internal mental processing. And interpersonal skills, then, that's about managing the team dynamics, how everyone interacts.
Precisely. They encompass effective communication, leadership, followership, which is just as important, and conflict resolution within the team. You know, when the scrub nurse notices a critical anomaly on the back table, but is afraid to speak up because of the hierarchy, that is a classic interpersonal failure rooted in poor team culture. And that's a core HF challenge.
This sounds exactly like what the aviation industry figured out decades ago. Can you maybe detail the origins of HF training there and its most famous application, crew resource management, or CRM?
Yeah, the origins trace way back to the U.S. Air Force in the 1940s, actually. But it really accelerated significantly in commercial aviation, particularly after analyses showed that the vast majority of catastrophic air disasters weren't due to mechanical failure, surprisingly.
Really? Not the plane itself.
Mostly not. They were due to failures in the cockpit crew's communication and decision-making processes. How the team functioned or failed to function, that realization led directly to the systematic application of crew resource management, CRM, starting around the 1980s.
And we've adapted CRM widely for surgery now. What are its core kind of functional components when you apply it in the operating room?
Okay, so CRM is designed to explicitly teach these team skills. Its components typically include: 1, effective communication, teaching structured communication techniques. You might have heard of SBAR: situation, background, assessment, recommendation. Ensures critical information gets transferred reliably.
Right, like a standardized script almost.
In a way, yeah. 2, creating a cohesive environment. This means actively breaking down that traditional steep hierarchy where the captains, or in our case, the senior surgeons, word is absolute, regardless of any dissenting evidence from other team members.
That's a big one.
Huge. 3 is empowerment. Training all personnel, the circulating nurse, the anesthetist, the junior trainee, to speak up non-judgmentally when they suspect an error or see a degradation in situational awareness. This requires real psychological safety.
The freedom to challenge without fear.
Exactly. And 4, addressing impairment. Actively monitoring and addressing factors like fatigue, excessive time pressures, stress, things that lead to cognitive tunneling or perceptual errors. Misreading a drug label, mishearing a critical instruction because you're exhausted or rushed.
That concept of empowerment, allowing a junior team member to effectively pause a surgery without fear of reprisal, that feels like the most difficult piece to actually achieve in a high-stakes, hierarchical setting like an OR. It really requires a fundamental cultural shift from the person in charge, doesn't it?
It absolutely does. It requires a leader to openly demonstrate humility and a genuine commitment to shared safety. The goal isn't necessarily consensus on every decision. It's about maximizing the use of all available intellectual resources in the room, regardless of rank, for the good of the patient. If the surgeon is operating under intense cognitive load, focusing hard on the technical task, they might miss a subtle sign on the monitor. The nurse, perhaps with a broader perspective at that moment, must feel safe enough to intervene.
Okay, so moving on from that explicit training, like CRM, the sources also introduced a really fascinating concept that sort of designs safety into the environment more passively. Nudge theory. This is the idea that we can shape choices without actually removing freedom of choice. Can you explain that a bit more?
Yeah, nudge theory, championed by Nobel laureate Richard Thaler and Cass Sunstein, it's become a staple of behavioral economics applied to safety and other fields. A nudge is basically any aspect of the choice architecture, how choices are presented, that alters people's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. It cleverly leverages human psychology and our known biases.
So we're essentially manipulating the environment in a good way to make the safest choice the easiest, most default choice.
That's a great way to put it. Can you give us a detailed example of a successful nudge in a clinical environment, maybe beyond the generic medication one we touched on earlier?
Okay, sure. Consider the really critical issue of hand hygiene compliance in hospitals. We all know staff should wash their hands or use sanitizer between patients, but compliance rates are often frustratingly low, particularly when people are rushed.
Right, a constant battle.
So a simple nudge is just moving the hand sanitizer dispensers. Instead of having them tucked away on a wall somewhere, if you place the dispenser directly in the line of sight in motion, maybe physically attached to the door handle of a patient room, or immediately next to the computer station where charts are always accessed, compliance rates shoot up significantly.
So you make it unavoidable almost.
Exactly. The person still retains the choice not to sanitize, nobody is forcing them, but the environment makes it slightly easier, more automatic, to perform the beneficial action. It reduces the friction. That's brilliant. You're not forcing compliance. You're designing the flow to encourage it. And linking back to that electronic medical records example, making the generic, cost-effective drug the default option that pops up first. The prescriber can still choose the expensive brand, but they have to actively click an extra button or two to opt out of the default.
These nudges are so powerful because they bypass the need for endless reminders, posters, or sometimes even aggressive sanctions. They accept that clinicians are busy, they rely on mental shortcuts, heuristics, and they design the environment to ensure those shortcuts naturally lead towards safety, efficiency, and ultimately value.
Okay, here's where it gets really interesting, and maybe a bit sobering. The statistics behind why we need this systemic approach. Just how pervasive is the problem of medical error? It forces us to adopt these behavioral engineering strategies. #3.3, the scope of medical error in risk management.
Yeah, we have to confront the core fact here. Medicine, especially invasive medicine like surgery, is a high-risk activity. Despite the most meticulous technical skill, despite the best intentions, the very nature of modern treatments means medicine is not, and frankly cannot be, completely risk-free. The goal of safety science isn't eliminating all risk, that's impossible, but minimizing preventable harm.
And when we look at the global scale of that preventable harm, the numbers really force us to sit up and pay attention, don't they? What does the global data tell us?
The scale is, well, it's staggering. It forces us to redefine what we even mean by safe healthcare. The World Health Organization estimates that 1 in every 10 patients worldwide suffers some form of preventable harm while receiving care in advanced hospital settings.
1 in 10, just think about that. If you look around a busy hospital waiting room, that statistic should give every single one of us pause.
It absolutely should. And when you look at the macroeconomic impact, the financial cost of unsafe care is just enormous. Iatrogenic patient harm, that's damage caused by the process of medical care itself, is calculated to be the 15th leading cause of global disease burden.
15th, wow. So it ranks higher than many widely recognized diseases in terms of mortality and disability.
In terms of mortality and disability adjusted life years, or dailies, yes, it places it right up there.
So a breakdown in the very system we designed to promote health is itself one of the top global causes of sickness and death. That's truly sobering.
And financially, the OECD reports that iatrogenic harm accounts for a shocking 15% of all hospital expenditure in OECD countries.
15% in the entire hospital budget, just dealing with the fallout from unsafe care.
That's the estimate. And this isn't just about litigation costs, which is what people often think of. This is the cost of extended hospital stays, readmissions due to complications, subsequent treatments, disability payments, lost income for patients. It's a profound drain on resources that could otherwise be dedicated to healing and prevention.
Okay, so when we acknowledge a problem of this magnitude, we naturally move into the realm of clinical risk management. The sources emphasize that tackling this requires a whole organizational culture change. It needs active involvement from senior management and promoting a, quote, blame-free environment. But how can a hospital realistically promise a blame-free environment when the outcome might be severe patient harm or even death? That sounds like an inherent contradiction. How do you square that circle?
It is genuinely the single biggest challenge in safety science, and it all hinges on the concept of a just culture. A truly blame-free environment doesn't mean that individuals are never held accountable for their actions. That would be chaos. What it means is that we learn to distinguish between different types of unsafe acts. There's simple human error slips, lapses, mistakes, which are often symptoms of poor system design. Then there's at-risk behavior, where someone takes shortcuts, maybe bends a rule, but doesn't intend harm, perhaps due to time pressure or perceived inefficiency of the rules. And then there's reckless behavior, a conscious, willful disregard for safety rules and known risks.
Okay, so human error, at-risk behavior, and reckless behavior. And the vast majority of incidents fall into the first two categories.
Overwhelmingly, yes. The just culture approach dictates that human error should lead to consolation and system redesign. At-risk behavior should lead to coaching and understanding why the shortcut was taken. Only reckless behavior warrants punitive action. The culture must shift away from the default question of who messed up to what were the systemic factors that allowed a competent, well-intentioned person to fail in this instance.
Because if staff fear punishment for honest mistakes or for highlighting risky situations,
They simply will not report incidents or near misses. And if they don't report, the organization cannot learn. It remains blind to its own vulnerabilities. Comprehensive risk management requires senior leadership to invest real resources in data management systems, clinical audit processes, root cause analysis capabilities, all underpinned by a non-punitive culture that emphasizes education and system redesign over blame. This is the only way to tap into that essential raw data of failure and near failure.
and to make sure we are learning effectively from these reports, we need to track different types of incidents carefully. Can you clarify the specific terminology that safety science uses to differentiate between these levels of failure?
Yes, terminology is important here. We track all patient safety incidents, which are generally defined as any preventable event or circumstance that could result in or did result in unnecessary harm to a patient. We then differentiate them based primarily on the outcome. First, you have adverse events. These are incidents that result in actual measurable harm to the patient. This harm can range from minor injuries, like a pressure sore, all the way up to permanent disability or death.
Okay, so actual harm occurred.
Second, and critically important for learning, are the near-miss events, sometimes called close calls. These are failures that definitely occur. The error happens but purely by chance, or maybe due to a timely intervention by someone. They cause absolutely no harm to the patient.
Like the nurse catching the wrong drug just before giving it.
Exactly. A near miss is essentially a free lesson. That system failure, maybe similar drug names, poor lighting in the pharmacy, unclear labeling it existed, it caused an error, but luck prevented harm. Those must be reported and analyzed with the same rigor as adverse events because next time, luck might not intervene.
Right, fix the system before it causes actual harm was the third category.
Third, we have no harm events. These are incidents where the error actually reaches the patient, for example. They receive a medication dose slightly later than scheduled, or maybe the wrong dose, but it wasn't clinically significant for them, but it results in no measurable harm. This might be due to the resilience of the patient or just the minimal nature of the deviation. Still worth tracking, but near misses often offer more learning potential.
Okay, so reporting those near misses is absolutely key, as that's where the systemic failures are revealed without the tragedy of patient injury. Let's look closer now at the common factors that actually drive these incidents. Based on the detailed analysis in the sources, particularly looking at Table 15.1, what are the most frequent contributing factors that come up again and again?
Well, the contributing factors are reliably categorized into human factors and system failures, but the reality is the overlap between the two is where most incidents actually reside. It's rarely just one or the other.
Okay, so starting on the human side.
On the human side, we consistently see things like inadequate patient assessment, maybe missing key symptoms or not getting a full history. We see errors in performance slips during a procedure, technical execution errors, and often deficiencies related to training or experience levels for a specific task.
But aren't those often just symptoms of a larger system problem, like the massive issue you mentioned earlier, clinician fatigue and overwork?
Absolutely. Fatigue, chronic overwork, and intense time pressures. These degrade cognitive performance significantly and are profound human factors in themselves. They lead directly to things like a lack of recognition of error dangers. A tired mind is a distracted mind. It's prone to confirmation bias. It misses subtle cues. And in surgery, as we know, distraction is risk.
Okay, so those are key human factors, often exacerbated by the system. What about the pure system failures, where the organization itself is the weak link? You mentioned earlier that one factor consistently ranks highest in frequency.
That factor, persistently across numerous studies, is poor communication. This includes poor communication during handovers between shift teams, which is a huge vulnerability, where critical context gets lost. It includes poor communication between different specialties, like surgery and ICU not being on the same page. And it includes poor communication between the clinical staff and the patient or their family. The sources consistently highlight this breakdown in communication as arguably the single most frequent system failure contributing to adverse events.
Can you give us a really tangible example of how a communication failure like that could cause a major incident?
Sure, let's take that handover from the operating room to the post-anesthesia care unit, the PCU or recovery room. It's a critical transition. The surgeon and the anesthetist might rapidly brief the PCU nurse on the procedure, key events, potential complications. A failure occurs if they use jargon the PACU nurse doesn't fully understand, or if the process isn't standardized. Maybe the nurse expects a certain critical fact, like the patient's lowest blood pressure during the case, to always be communicated, but the anesthetist forgets it because they're tired and relying purely on memory.
Okay.
Then, if that patient suddenly deteriorates in the PCU, the receiving team is starting their recovery effort with missing or maybe misunderstood critical context. That delay in appropriate response can be catastrophic.
That breakdown is a perfect example of a latent failure, isn't it? The system never enforced, say, a closed-loop, standardized handover protocol using something like SBAR.
Yeah.
The weakness was always there.
Exactly. The potential for error was built into the routine process. What are some of the other major system failures cited in the sources?
Well, they include things like inadequate staffing levels, which forces existing staff to rush and take shortcuts. Disconnected or overly complex reporting systems, which actively discourage incident reporting because it's too much hassle. Problems with drug similarities look-alike, sound like drugs that need careful management by the pharmacy system, clear labeling, separate storage, and issues with environment design, things like poor lighting in key areas, or constant high levels of noise and interruptions that degrade concentration and situational awareness.
And often, if you trace these failures back far enough, you often find they're traceable back to poor governance structures, maybe insufficient investment in safety infrastructure, or sometimes even explicit cost-cutting measures that inadvertently eroded the system's defenses over time. The latent failures accumulate.
Okay, so this fundamental shift from focusing solely on the poor communication of an individual nurse or doctor to focusing on the system that allowed poor communication to become the norm, or even inevitable, that really is the essence of modern safety science, isn't it? Let's briefly contrast that traditional view with the modern approach, just to make it crystal clear.
Sure. Traditionally, in medicine and many other industries, we adopted the person approach to error. This view accepts that humans are fallible, yes, and it tends to categorize errors based on the action. Errors of commission, doing something wrong, errors of omission, failing to do something required, like forgetting a medication, Or errors in execution. Doing the right thing but doing it incorrectly, like a slip of the scalpel.
Seems logical enough on the surface.
It does. But the primary issue with this approach, especially when applied reactively after an incident, is that it often restricts organizational learning. Why? Because the investigation often terminates once the bad apple or the failed individual is identified and typically disciplined or retrained. It looks backward and focuses blame.
Right. It provides an easy target, satisfies that institutional need for accountability perhaps, but it doesn't actually solve the underlying problem that allowed the error to happen in the first place. The next person might make the same mistake tomorrow.
Exactly. The modern system approach, in contrast, recognizes that adverse events rarely, if ever, have a single isolated cause. It's almost never just one person's fault. The system itself, the organizational structures, the protocols, or lack thereof, the management layers, the technology, the culture, all adds complex potential failure points that interact with basic human fallibility. So the emphasis shifts entirely to examining the context. Why did the system fail? Why did the defenses not work? What were the conditions that allowed a competent operator to make that mistake?
Okay, and within this broader system approach, there's a newer, really crucial distinction being made in the safety literature, safety I versus safety 2. You mentioned this is a massive paradigm shift. Tell us about that.
It truly is a profound shift in thinking. Safety I represents the traditional reactive safety management model we've known for years, even within the system approach. It is fundamentally focused on preventing errors after they have occurred or based on known past failures. It asks us the question, why did things go wrong? Its primary goal is the minimization of failure by investigating incidents, identifying root causes, and then establishing defenses barriers, rules, checklists against those known risks. It's essentially defensive engineering.
So if a wrong side surgery happens, a safety I approach asks, which checklist step was skipped? Who didn't follow the protocol? And the response is often disciplinary action or maybe adding another rule, another check.
Precisely. It reacts to failure. Now, Safety 2, a concept really pushed forward by figures like Professor Eric Hollnagel, flips the script entirely. It starts by acknowledging that, despite all the inherent complexity and flaws in our systems, work usually succeeds. Healthcare, most of the time, goes right. Clinicians constantly adapt, they innovate, they perform successfully, often in chaotic and under-resourced environments. So, Safety 2 asks the complementary question, why do things go right?
Oh, okay. So it studies success instead of just failure.
Exactly. It focuses on understanding and enhancing system resilience. It looks at how clinicians adapt and innovate successfully under varying conditions. It tries to increase the capacity of the system and the people within it to deliver effective care reliably, even when things don't go perfectly according to plan. It's proactive engineering for success.
That feels like a fundamentally more optimistic view. It trusts the adaptive capacity of the people actually doing the work. It investigates success to figure out how to engineer more success, rather than only investigating failure to prevent recurrence.
Yes, that's a great way to frame it. For example, a safety eye investigation might focus intensely on the one time a critical drug was administered 30 minutes late, figuring out the specific delay. A Safety 2 investigation, complementing that, might look at the 6 previous times that same drug was administered perfectly on time, despite maybe staffing shortages or equipment issues. It would try to understand the workarounds, the clever communication strategies, or the informal solutions the team developed to make that success happen under pressure.
And then try to formalize those successful adaptations system-wide.
Exactly. Make the successful way the standard way. The sources emphasize that sophisticated, high-reliability organizations today need to assimilate both Safety I and Safety 2 thinking. You need to learn from failure, but you also need to learn from and actively support success.
Okay, to help make these abstract concepts stick for the listener, safety science uses some really powerful analogies or models. Let's look at 2 key ones mentioned, starting with Heinrich's safety pyramid.
Right. Heinrich's model, which actually stems from industrial safety studies back in the 1930s, is visually very compelling. It depicts safety incidents as a pyramid. At the very peak, you have a single catastrophic injury or fatality. Below that, there's a larger number of less severe, minor injuries. And below that, forming the vast base of the pyramid, are a huge number of near misses and unsafe acts that cause no injury at all.
So the one major error that makes the headlines is really just the visible tip of a massive iceberg of underlying systemic weaknesses and risky behaviors.
That's the core message. The model stresses that if an organization focuses its attention, its reporting systems, and its resources on identifying and addressing the high volume of near misses and unsafe conditions at the base of the pyramid, it automatically and inevitably prevents the rare, costly catastrophe waiting at the peak. It provides the clear rationale for that relentless reporting of near misses, even those that seem trivial at the time. They are precursors, warning signs of potential disaster.
Okay, that makes sense. Address the foundations to keep the top stable. And the most iconic model, the one probably everyone listening has seen in some form, is James Reason's Swiss cheese model. This feels like the perfect analogy for shared systemic failure.
It really is the go-to model for explaining complex system failures. The Swiss cheese model explains accident causation not as a single point failure, but as the result of multiple defensive layers, barriers, checks, protocols, safeguards, technologies, people failing simultaneously. Reason asks us to visualize these defensive layers as slices of Swiss cheese. Each individual layer, each slice, has holes in it. These holes represent weaknesses. They could be active errors, like a nurse forgetting a critical step in the moment, or, more importantly, latent failures, like a poor hospital policy that was written years ago, inadequate training programs, faulty equipment, or chronic understaffing.
And the crucial point is that these holes are usually scattered randomly across the different slices. Most of the time, a hazard hits a solid part of the next slice and is stopped. But harm only reaches the patient when, by misfortune, the holes in multiple sequential slices momentarily align.
Exactly. Creating a clear, unimpeded trajectory, an accident opportunity for the hazard to pass through all of the defenses and reach the patient at the end. It powerfully illustrates that multiple failures across different levels of the system are usually required for a catastrophe to occur. A latent failure, say, two similar-looking drug vials being routinely stored side by side in the pharmacy, might exist for months or even years without causing any harm.
Right, the potential is there, but the holes haven't lined up yet.
Precisely. But then one day, that latent failure, poor storage, aligns with an active error, maybe a tired pharmacist under pressure grabbing the wrong vial, and perhaps another latent failure, like a poorly designed electronic medical record system that doesn't automatically flag a potential contraindication for that wrong drug. Suddenly, the holes align and harm occurs. The model mandates shared responsibility across every layer of the system, from the CEO setting budgets and safety priorities, down to the frontline clinician like the scrub nurse performing the final instrument count. Everyone owns a slice of the cheese. #FEE V. Strategies for patient safety and surgical implementation.
Okay, we've established the nature and scale of the problem, and we have these models like Swiss cheese to help us understand how failures happen. Now let's pivot to the practical tools and strategies used to actively build safety, starting with the intervention that perhaps generated the most dramatic and rapid improvement globally, the surgical safety checklist.
Yes, the checklist is almost the poster child for the system's approach in action. Following that devastating realization of the sheer scale of global surgical harm, the WHO launched its second global patient safety challenge called Safe Surgery Saves Lives. And the core component of that challenge was the mandatory systematic use of a standardized safety checklist during surgery.
And the data supporting this simple, apparently low-cost intervention is, well, it's astounding, isn't it?
It is genuinely revolutionary. Multiple large-scale studies, including the initial WHO pilot study across diverse global settings, associated the introduction of this perioperative surgical safety checklist with an immediate and dramatic reduction in perioperative mortality. Death rates dropped from around 1.5% down to 0.7%, a massive impact.
Wow, nearly halved.
And perhaps even more profoundly, major inpatient complications, things like sepsis, major bleeding, pneumonia, fell significantly too, from about 11.0% down to 7.0%. These numbers powerfully demonstrate that many of the failures being captured and prevented by the checklist were not primarily failures of complex surgical skill, but rather basic failures of process, communication, teamwork, and confirmation. Getting the basics right every single time.
So what does the WHO checklist actually require? How is it structured to try and maximize its impact across the entire surgical team, surgeon, anesthesia, nursing?
The checklist mandates specific confirmation checks done verbally with the whole team involved at 3 obligatory, non-negotiable time points during the surgical journey. These points are strategically designed to capture critical failures before they become irreversible. The first is the sign-in. This happens before the induction of anesthesia. It involves at least the anesthetist and the nurse, often with the patient still awake if possible. They confirm the patient's identity, the exact site of surgery, and that it's marked. allergies, airway risks, and whether all necessary equipment like the anesthesia machine and monitors have been checked and are functional. This aims to prevent wrong patient or wrong procedure errors right at the start.
Okay, sign in before anesthesia. What's next?
Second is the timeout. This occurs immediately before the skin incision is made. This is a critical pause where the entire team surgeon, anesthesia, nursing, trainees, everyone stops what they're doing. They verbally confirm again the patient's name, the exact procedure being done, and the correct surgical site. They also introduce team members by name and role, and importantly, discuss anticipated critical events like the surgeon outlining expected major blood loss, or the anesthetist highlighting specific patient concerns, or everyone agreeing on the antibiotic prophylaxis plan. This is where those CRM principles of shared understanding are really enforced.
The pause point.
Yeah.
Everyone on the same page before cutting? Makes sense. And the third?
The third is the sign out. This happens before the patient leaves the operating room, often during or just after skin closure. The team confirms several things. The name of the procedure recorded, that the instrument, sponge, and needle counts are correct to prevent retained foreign objects, how any surgical specimens taken are labeled, and if there were any equipment problems to address. They also briefly review the key concerns for post-operative recovery and management.
It sounds incredibly simple on paper. Almost insultingly simple in some ways. Yet the power seems to be that it forces everyone, including the senior surgeon, to stop, listen, and verbally confirm critical information with the entire team present.
That is precisely the magic and the challenge. However, the sources are very quick to note a crucial limitation. The checklist is not a safety panacea on its own. It won't magically fix everything. It's designed as a simple cognitive aid, a reminder tool. But it must be coupled with a fundamental attitude change within the team, an active, visible leadership supporting its use. If the team just drones through the checklist items mechanically, just to tick a box for an audit, a phenomenon sometimes called checklist ritualism, then its real value in fostering communication and teamwork is completely lost.
So the implementation, the how, is just as important as the what on the list itself. What are the key factors that the sources cite for successful checklist adoption in hospitals?
Yeah. Implementation is everything. Successful adoption typically requires several things. Having local champions, respected clinicians who actively model proper use and believe in it. It needs extensive discussion and education among all staff about the why behind it, not just the what. Genuine multidisciplinary involvement is key, ideally. Anesthesia, nursing, and surgical teams should work together to adapt and implement the checklist workflow for their specific environment.
Makes sense. Ownership.
And crucially, leadership from the head surgeon down must consistently treat the checklist not as a bureaucratic chore to be rushed through, but as a vital cognitive forcing function designed to enhance team performance and protect the patient. If the surgeon sighs and rushes it, the rest of the team quickly learns it's optional, or just for show.
Okay. Now, you made a really critical point earlier. Surgery isn't just the 90 minutes or however long under the knife in the OR. The data suggests the majority of errors actually happen outside the operating room itself. Where should safety attention be focused along that entire surgical pathway?
Yeah, that data is really compelling and often surprising to people. Studies suggest somewhere between 53% and 70% of surgical errors actually occur either preoperatively, before the patient even gets to the OR, or postoperatively during recovery. This really underscores the need to target safety interventions across the entire surgical pathway, not just inside the theater doors.
So what kind of preoperative failures are common?
Preoperative failures can include things like inaccurate initial assessments or diagnoses, poor coordination of necessary ancillary tests like imaging or labs, failures in optimizing the patient's condition before surgery, or even simple process failures like failing to administer prophylactic antibiotics within the correct time window before incision.
And postoperatively.
Postoperative failures often relate to delayed recognition or inadequate management of complications like bleeding or infection, poor fluid management on the wards, medication errors during transitions, and, again, handover failures when the patient is transferred from recovery to the ward or from the ward to the ICU. Communication gaps again.
This focus on the complete pathway naturally brings us to some crucial communication points that happen at the bedside, particularly informed consent. This feels like where ethics, patient safety, and the legal duty of care all intersect.
Informed consent is absolutely paramount, ethically and legally. It represents respect for the patient's autonomy, their right to self-determination. Surgery, by its nature, involves invasion and risk. The patient must be able to weigh those potential risks against the potential benefits based on their own values, life goals, and tolerance for uncertainty. The knowledge gap between a surgeon and a patient is usually immense, so the surgeon has a profound ethical duty to act as a transparent, honest, and reliable guide through that complex decision-making space.
And the sources are quite specific, detailing 6 essential pieces of information that are generally required for consent to be considered truly valid and informed. It's clearly much more complex than just getting a quick signature on a form before wheeling the patient down the corridor.
Absolutely. Getting the signature is the end of the process, not the process itself. A formal consent discussion must clearly disclose, in understandable language, 1. The patient's condition and the reason why surgery is being recommended. 2. The type of surgery being proposed, including a basic explanation of what it involves and how it aims to correct or manage the condition. 3. The anticipated prognosis and the expected common side effects or consequences, things like recovery time, pain levels, common post-operative discomforts. 4, and this is crucial, the unexpected but significant hazards. The serious but perhaps rare risks specific to that particular procedure, even if they have a low probability of occurring. Patients need to know the worst-case scenarios, however unlikely.
Right, the low probability, high impact risks.
That's exactly. 5. Alternative and potentially successful treatments, including non-surgical options if they exist. Patients have a right to know all their choices. And 6, the specific consequences of having no treatment at all. What is the likely natural history of the condition if they choose not to proceed with surgery? This allows the patient to truly weigh the risks of intervention against the risks of non-intervention.
And the sources really stress that consent isn't a single event, a one-off conversation. It's a process. It often requires multiple interactions and adequate time for discussion. Why is it so dangerous to treat it as just a single tick box exercise?
Because a patient who is likely feeling stressed, anxious, perhaps unwell, and facing a major life decision simply will not absorb all that complex information effectively in one short conversation, especially if it's filled with medical jargon. Proper consent must involve multiple touch points. Ideally, it starts weeks before the procedure in an outpatient clinic, allowing the patient time for reflection, discussion with family or advisors, and the opportunity to formulate and ask follow-up questions later. Furthermore, the person obtaining the consent should ideally be the surgeon who will actually be performing the operation, or at least someone with equivalent expertise who can accurately describe the risks and answer detailed questions. A signed form is merely the documentation that a discussion happened. True valid consent is only achieved when the surgeon is genuinely satisfied that the patient understood the disclosure and voluntarily agreed.
Okay. And if, despite all these layers of safety of the checklist, the consent process and adverse event still occurs, the communication duty doesn't end there, does it?
Yeah.
It actually triggers something else, the duty of candor.
Yes. Open disclosure, or the duty of candor, requires both institutional and professional honesty following patient harm. In many places, like the UK, this is now a statutory duty, meaning there's a legal requirement for healthcare providers and organizations to communicate truthfully and openly with patients when things have gone wrong. This involves providing the patient, or their family, with a full, honest explanation of what happened based on the facts known at the time. It includes discussing the potential short and long-term consequences of the harm. It requires outlining a clear plan to fix the problem if possible or manage the fallout. And importantly, it includes offering a sincere apology or expression of regret for the harm suffered.
I just want to clarify something there. Does the duty of candor apply even if the complication was a known rare risk that was discussed during consent and maybe wasn't caused by any substandard care?
Yes, absolutely. The duty to be open and honest persists, irrespective of fault or blame. If a rare known complication occurs during a perfectly executed procedure, the obligation is still to be candid with the patient, explain what happened and why, as best as possible, manage the consequences, and apologize for the harm and distress caused, even if the care delivered was technically impeccable. It's about maintaining trust and ensuring the patient remains informed and involved in their ongoing care plan, especially when things deviate from the expected course.
Okay, that's clear. Now let's bring the focus back inside the OR for a moment and discuss how those non-technical skills we talked about earlier, particularly situational awareness and emotional intelligence, actively help prevent things from going wrong in the first place.
Right. Situational awareness, or SA, is really the cognitive foundation of safety in dynamic environments. It's formally defined in 3 levels: perceiving the critical elements in the environment, understanding the meaning and significance of that information in context, and then projecting the future status of those elements. In a complex surgery, high SA might involve the surgeon continuously monitoring the patient's vital signs on the screen, keeping track of blood loss in the suction container, being aware of the precise position of all surgical instruments near critical structures, while simultaneously monitoring the atmosphere in the room, the stress levels, the focus of the team members. It's a dynamic mental model.
Wow, that sounds incredibly demanding. And emotional intelligence, then, how does that fit in? Is it key to managing that team dynamic, especially when stress starts to inevitably mount during a difficult case?
Absolutely. Emotional intelligence, or EI, often defined using Salavi and Mayer's model, is the ability to monitor one's own and others' feelings and emotions, to discriminate among them, and to use this information to guide one's thinking and actions. An experienced surgical leader with high EI uses it constantly. They can spot subtle cues, maybe a scrub nurse's slight hesitation before passing an instrument, a sudden quietness from the anesthetist, a trainee looking overwhelmed. They pick up on these nonverbal signals and can proactively intervene. Maybe ask a clarifying question, offer support, or adjust the plan before that stress, confusion, or loss of focus translates into a dangerous error. It's about reading the room and managing the human element proactively.
This links directly, doesn't it, to the current burnout crisis that we hear so much about in medicine, which is increasingly being recognized not just as a workforce issue, but as a profound patient safety issue as well.
Oh, absolutely. There is a direct, quantifiable link that's been demonstrated between chronic tiredness, mental fatigue, high stress levels in clinicians, and the likelihood of them making medical errors. Burnout, typically defined as a syndrome of emotional exhaustion, depersonalization, treating patients impersonally, and a reduced sense of personal accomplishment is rampant in medicine, often driven by chronic workplace stressors like excessive workload, lack of control or autonomy, and crushing administrative demands.
And this presents that really difficult ethical and systemic trade-off we touched on earlier, particularly when it comes to regulating the working hours of trainees like junior doctors.
It's a constant balancing act, and there's no perfect answer. Reducing trainee working hours, like the European Working Time Directive aimed to do, demonstrably reduces fatigue, which should be good for patient safety by reducing fatigue-related errors. However, the inevitable consequence is that it necessitates far more frequent handovers of patient care between different clinical teams. And as we've already established, every single handover is a communication friction point. It's a potential hole aligning in the Swiss cheese that risks a critical loss of information or continuity of care. So the institution has a responsibility not just to manage working hours, but also to diligently manage the working environment, to minimize unnecessary stress, and crucially, to mitigate that handover risk through rigorously enforce standardized structured communication protocols, like mandatory bedside handovers using tools like SBAR, hashtag Cytag seconds. The surgeon's accountability and quality improvement. Okay, so even when the system is optimized as much as possible, with checklists, good communication protocols, managed working hours, the individual surgeon still remains accountable for their unique contribution at the sharp end, right? The surgical context demands rapid, critical decision-making right there at the coalface, as the sources put it. Cuschieri, a prominent surgeon scientist, detailed specific categories of errors that patients and the system often attribute directly back to the operating surgeon's judgment or skill.
What are those specific coalface failures, where the surgeon's immediate judgment or action is seen as crucial?
Well, they include failures in overall case management strategy, like diagnostic errors, maybe misinterpreting preoperative imaging or intraoperative findings, resuscitation errors, like mismanaging a patient who becomes unstable or bleeds unexpectedly during the procedure, and certain types of prescription errors related to the surgical plan. Critically, there are also failures of situation awareness and teamwork, which ultimately fall on the surgeon as the team leader to manage effectively in the OR. Did they fail to notice the team struggling? Did they fail to communicate the plan clearly? And then, of course, there are the purely technical and operative errors, things like inadvertent injury to surrounding nerves or blood vessels, incomplete removal of a tumor, or problems with anastomosis or reconstructions. These are the classic slip-of-the-knife type errors, though often they have systemic contributors too.
Those technical failures, especially the really catastrophic ones, bring us to the concept of a never event. These are failures considered so profound, so preventable, that the assumption is the system should have made them impossible.
Exactly. A never event is defined, usually by national patient safety bodies, as a serious, largely preventable patient safety incident that should not occur if the available preventative measures like the WHO checklist protocols, mandatory site marking policies, clear labeling systems have been implemented and used correctly. The consequences are often catastrophic for the patient, and their occurrence signals a massive, fundamental breakdown in the systemic safety barriers. The key is that they are considered wholly preventable. Examples include things like performing surgery on the wrong patient or the wrong body part, wrong site surgery, leaving a foreign object like a surgical sponge or instrument inside the patient after surgery is finished, or administering medication via the wrong route causing death or serious harm. Their occurrence demands immediate investigation and system redesign.
Okay, so to reduce those technical errors specifically, we obviously need proficiency. Let's look at how surgical skill actually develops through the lens of the learning curve. The sources differentiate between non-proficient execution and high proficiency execution. What's the difference in terms of cognitive load?
Yeah, proficiency development is key, and it comes through rigorous, deliberate practice, coaching, feedback, and lots of repetition. Our sources describe two distinct levels of motor skill execution relevant here. Non-proficient execution is very demanding on the brain. It's characterized by conscious control processing. The surgeon has to actively think through every small movement, every step of the task. Like, okay, now I need to angle the needle like this, now apply this much tension.
Hmm.
This conscious execution is typically slow, it's mentally fatiguing, and crucially, it consumes a huge amount of cognitive bandwidth, leaving less mental capacity available for maintaining broad situational awareness or managing unexpected events.
This sounds exactly like me when I first learned to drive a stick-shift car. Every single gear change required 100% of my focus, and I couldn't possibly hold a conversation at the same time.
That's a perfect analogy. Now, high proficiency, conversely, is the state of the experienced master surgeon performing a routine procedure. The execution is driven largely by automatic, unconscious processing. The technical steps flow almost effortlessly, they feel intuitive, and they are relatively untiring. This frees up significant cognitive resources, allowing the expert to dedicate their attention to the bigger picture, monitoring the patient's overall status, anticipating potential problems, managing the team dynamics, and dealing effectively with any unexpected complexities or variations in anatomy.
And this automation of skill is mapped out beautifully in that classic model, the hierarchy of competence, which I think was mentioned as figure 15.4 in the source. It shows the journey from complete ignorance to effortless mastery.
Yes, it charts the cognitive state of the learner. A complete novice starts at unconscious incompetence. They don't even know what they don't know. They're unaware of the skill deficit. They then progress, usually through feedback or failure, to conscious incompetence. Now they realize they lack the necessary skill, which can be uncomfortable but is necessary for learning. The crucial training stage is achieving conscious competence. They can perform the operation correctly, maybe even very well, but only through intense concentration, focus, and deliberate effort, like your manual driving example. They have to think about every step. A trainee at this level can still perform a good operation, it just might take longer and be more tiring for them. The ultimate goal of training and experience is reaching unconscious competence, where the technical skill becomes second nature, intuitive, almost automatic, requiring minimal conscious mental effort.
Okay. But even a surgeon operating at that peak level of unconscious competence is still human. Mistakes can still happen. Unforeseen things occur. Which brings us to that really important and relatively recent concept of the second victim. What is that?
Yes, this is a critical concept for understanding the full impact of adverse events, developed initially by Dr. Albert Wu. It acknowledges that when a severe adverse event occurs, it obviously impacts the patient they are the first victim, but it also often profoundly impacts the clinicians involved in the event. The second victim is the healthcare provider who experiences significant personal and professional distress, emotional, psychological, sometimes even physical trauma in the aftermath of being involved in an error or an unexpected adverse patient outcome. This can manifest as guilt, shame, anxiety, depression, flashbacks, loss of confidence, fear of litigation, and in some tragic cases, even job abandonment or suicide.
That is so critical for organizational risk management to understand and address, because if the system doesn't support the second victim, not only does that individual clinician suffer immensely, but their ability to safely and effectively deliver care to future patients is likely compromised as well.
Absolutely. A truly robust, mature risk management system must include proactive support networks for staff involved in adverse events. This might include confidential peer support programs, access to psychological services, ensuring fair and just investigation processes, linking back to just culture, and fostering a culture where it's okay to admit vulnerability and seek help. Focusing only on patient-centric care without actively supporting the well-being and resilience of the people delivering that care is ultimately self-defeating for the entire system's safety goals.
Okay, so given all this complexity, the systems, the human factors, the need for proficiency, the impact of errors, how do institutions systematically achieve sustained change and improvement? How do they move beyond just fixing single incidents reactively?
Yeah.
This brings us to formal quality improvement methodologies.
Right. Quality improvement, or QI, is not just about having good intentions or working harder. It's a continuous, systematic process for making things better. It absolutely requires measurement. You can't improve what you don't measure, and it relies on established frameworks for designing, testing, and implementing changes. It leverages improvement science to actively redesign clinical and operational processes, aiming for better patient outcomes, enhance system performance, and improve professional development.
One of the most common frameworks used globally, mentioned in the sources, is the model for improvement, often known by its primary tool, the PDSA cycle. What's that about?
The model for improvement, heavily based on the revolutionary work of W. Edwards Deming in post-war Japan and later in the U.S., is elegantly simple but powerful. It's driven by three fundamental questions. 1, what are we trying to accomplish? Setting a clear aim. 2, how will we know that a change is an improvement? Defining clear measures. And 3, what changes can we make that will result in improvement? Generating ideas for change. Deming's fundamental premise, famously, was, in God we trust, all others must bring data. Improvement requires evidence, not just opinion.
Okay, clear aim, clear measures, ideas for change. And the engine for testing those ideas is the Plan, Do, Study Act, or PDSA cycle. This is all about rapid, small-scale testing before attempting to implement widespread change, right? Can you walk us through a quick clinical example of a PDSA cycle?
Sure. Let's take a common problem in many hospitals. Delays in surgical start times, which severely impacts OR efficiency, staff frustration, and potentially even patient safety if schedules get compressed. A QI team identifies this problem. Their aim is to reduce first case tardiness by 50% within 3 months. Their measure will be the percentage of first cases starting within 5 minutes of the scheduled time. They brainstorm ideas and hypothesize that implementing a standardized preoperative checklist completed by the nursing team 30 minutes before scheduled start time will help. Now, the PDSA cycle. 1, plan. They plan to test this new 30-minute checklist protocol with just one surgical team for 1 week only. They predict it will reduce their late starts by 10% that week and outline how they'll collect the start time data. 2, do. They carry out the test. They implement the new 30-minute checklist with that one team for the week, carefully collecting the start time data, recording any issues encountered during the process, and maybe getting quick feedback from the clinicians involved. 3, study. At the end of the week, they analyze the data they collected and compare it to baseline data. The late starts actually decrease. By how much? Did the checklist cause any new problems or delays elsewhere? Let's say they find that late starts for that team dropped by 15%, which is great, but the nursing staff reported feeling rushed to complete it exactly 30 minutes beforehand. 4, act. Based on the study phase, the team acts on the data. They decide to adopt the checklist because it worked, but they adapt the timing, maybe making it 45 minutes pre-op instead of 30, based on the feedback. They then plan their next PDSA cycle, perhaps testing this refined protocol across all surgical teams next month before making it permanent hospital policy.
That systematic, data-driven, iterative approach seems so much smarter than just rolling out a massive, untested change across the whole hospital that might fail spectacularly or have unintended consequences. It's about continuous learning and refinement.
It is the absolute bedrock of sustained, successful change in complex systems. Another powerful methodology mentioned is Lean, sometimes referred to by its Japanese principle of Kaizen, continuous improvement. This originated in the Toyota manufacturing system, but has been widely and successfully adapted for healthcare environments.
Right. Lean methodologies are famous for focusing relentlessly on the elimination of waste. How is waste defined in the complex environment of a hospital? It's not like building cars. And what are the key types of waste that Lean specifically targets in healthcare?
That's a great question. Lean defines waste, Muda in Japanese, as absolutely any activity that consumes resources, time, money, supplies, space, staff effort, but does not add value from the perspective of the patient. By systematically identifying and eliminating this non-value-added waste, we can increase efficiency, speed up processes, reduce costs, improve staff morale, and ultimately enhance patient safety and experience. The sources, referencing common Lean frameworks adapted for healthcare, like Table 15.6, identify 7 classic types of waste to look for.
Okay, what are the 7?
1. Overproduction, doing more than is actually needed or doing it too early. In healthcare, this might be ordering routine batteries of unnecessary preoperative tests just in case, or maybe preparing surgical instrument trays far in advance that then need reprocessing. A lean solution involves implementing standardized, evidence-based assessment pathways and just-in-time supply systems. 2. Waiting. Any idle time where patients are waiting for a consultation, a bed, a test result, theater time, or staff are waiting for equipment, information of the previous procedure to finish. This not only frustrates everyone, but ties up expensive resources like OR time. Solutions might involve staggered admission times precisely aligned with the operating schedule or improved communication flows. 3. Transportation. Unnecessary movement of patients, materials, or information. For example, wheeling a patient back and forth multiple times between different departments for various imaging studies that could have been coordinated better, or staff constantly walking long distances to fetch supplies. 4. Overprocessing. Performing complex steps or using overly complicated processes when a simpler approach would suffice and add the same value. Maybe requiring 3 different signatures for a routine, low-risk procedure consent form, or using overly sophisticated equipment for a simple task. 5. Inventory. Holding excessive stocks of supplies, drugs, or equipment that risk expiring, becoming obsolete, or just tying up capital and storage space. Think cupboards overflowing with unused consumables. 6. Motion. Unnecessary physical movement by staff during their work. A classic example is a nurse in the operating room having to search multiple different supply cupboards scattered around the room to find a commonly used specialized suture during a critical point in the surgery. A lean solution here is standardizing the OR layout using principles like 5S, everything has a specific place, is always in its place, and clearly labeled. Saves precious time and reduces frustration. 7. Defects. Errors that require correction or rework. This is the ultimate waste in healthcare. Things like a surgical site infection requiring further treatment and prolonged hospital stay, a medication error needing an antidote, or a surgical complication requiring a second unplanned reoperation. Preventing defects is the highest goal.
Wow. The application of lean thinking is fascinating because it really forces clinicians and managers to look at the entire clinical process, not just as a series of medical events, but as a system of flow, value, and efficiency, viewed through the patient's eyes.
It fundamentally shifts the mindset from we are just incredibly busy to hang on, much of this busyness is actually unnecessary, non-value added activity that we could potentially eliminate.
Okay, so whether using PDSA cycles or lean tools to measure the success of these QI efforts, we need robust, consistent metrics. How do we typically measure quality across the organization? The sources mention 3 key domains.
Yes, quality measurement is traditionally organized into 3 interconnected domains, often credited to Avedis Donabedian: structure, process, and outcomes. Structural measures assess the characteristics of the healthcare, setting itself the resources and arrangements in place that affect its capability to deliver care. This includes things like the ratio of registered nurses to patients on a ward, the availability of specialized equipment like MRI scanners, or whether a hospital has formal, written policies for things like postoperative patient observation or sepsis management. It's essentially measuring the inputs and the environment itself. Are the basic building blocks for quality in place?
Okay, structure is the setup. What's process?
Process measures assess what the healthcare provider actually did and how well they did it, the interactions, the activities, the implementation of procedures. Process measures track whether the care delivered adheres to recommended best practices or established standards. Examples include measuring the percentage of surgical patients who received appropriate antibiotic prophylaxis within the correct time frame, tracking whether operating lists consistently start on time, or auditing how often diabetic patients have their blood sugar checked according to protocol. Process measures track the adherence to the planned, ideal path of care.
And finally, the one that arguably matters most to the patient: outcomes.
Exactly. Outcome measures describe the effect of the care on the patient's health status. This is the ultimate measure of quality and value. While historically, healthcare outcomes often focused heavily on negative events like mortality rates or major complication rates like infection or readmission, the modern standard, as we discussed with value-based care, increasingly emphasizes patient-reported outcome measures, PROMs.
Right, PROMs again. This feels like a critical evolution because They ensure the patient's priorities and experiences are central to how we define success, not just clinical metrics that might not reflect what matters most to them.
Absolutely. The patient ultimately defines what good recovery means for them. Is it being able to return to work quickly? Is it regaining functional capacity to play with grandchildren? Is it effectively managing chronic pain levels? The whole pursuit of quality improvement is increasingly and rightly centered on patient-centered co-design, ensuring that the outcomes we strive for and measure are those genuinely prioritized by the people receiving the care.
This entire complex discussion, from value-based care through human factors, error models, safety strategies, and QI methods, it really culminates in the fundamental requirement for systems thinking and a specific type of leadership, doesn't it? It's about seeing the entire web of interdependencies across the whole organization.
It is the ultimate requirement for achieving and sustaining excellence in complex systems like healthcare. You simply cannot improve surgery in isolation. You have to understand its intricate links to anesthesia, critical care, nursing, pharmacy, sterile services, supply chain, IT, everything. Sustained quality improvement demands unwavering organizational commitment, right from the very top down. It requires that non-punitive just culture we discussed, encouraging reporting and learning. And critically, it requires leaders who demonstrate what's sometimes called humble leadership leaders, who acknowledge they don't have all the answers, who actively listen to frontline staff, empower teams to solve problems, and rely on the collective expertise and insights of everyone within the system. The goal has to be a constancy of purpose, relentlessly focusing on creating value for the patient by continuously improving the system. Hashtag tag outro. So if we were to summarize what we've detailed today, it really represents the necessary intellectual evolution of surgical practice and healthcare more broadly. Patient safety is no longer perceived primarily as a matter of demanding flawless individual perfection from clinicians, which we know is impossible. Instead, it's fundamentally understood as a challenge of systems engineering. We must actively adopt behavioral tools like nudge theory. We need to embrace proactive concepts like safety too that learn from success. And we must systematically utilize rigorous methodologies like PDSA and Lean to consciously engineer processes that make it structurally easier, more automatic for competent, well-intentioned clinicians to do the right thing for every patient every single time.
Yeah, and the crucial takeaway for you listening is perhaps that shift in where accountability lies, or at least how it's shared. Excellence in modern healthcare is now defined and measured across the entire system. The structure of the resources and environment, the reliability of the process of care delivery, and ultimately, the patient-centered outcome achieved. It's not solely about the technical brilliance of a single surgeon anymore, although that's still vital, of course.
The modern quest for surgical excellence and patient safety in general is deeply rooted in the behavioral science of human factors and the engineering principles of system design.
So what does all this mean for you, perhaps listening to this outside of a healthcare context, regardless of your own professional environment? We've highlighted the absolutely essential role of structured systems, things like the surgical checklist, in managing high-risk medical environments. The data emphatically shows the majority of catastrophic surgical errors occur not due to a fundamental lack of technical skill in the individuals, but rather due to latent failures in communication, teamwork, and underlying system design flaws, the holes in the Swiss cheese. Now, if that is demonstrably true for the operating room, arguably one of the ultimate environments of complexity, high stakes, and risk, then here's the final thought to leave you with. What unseen systemic failures, what latent conditions might exist right now in your daily professional environment? Whether you're managing complex supply chains, building intricate software, running a large team, or teaching students. What problems in your work, what recurring frustrations or inefficiencies could potentially be solved? Not necessarily with more training or a stronger lecture telling people to be more careful, but perhaps with something as simple as a well-designed, multidisciplinary checklist. Or a subtle nudge that makes the correct, safe, or efficient default choice the easiest one for everyone to take. We challenge you. Can you identify the latent conditions and potential coalface errors in your own professional context? And could you start designing a better, safer, more reliable system today?